Okay, so ladies and gentlemen, we're going to move on then in this colorectal session to the next talk on endoscopic resection of large colorectal polyps. And I can't think of anybody that's more qualified in talking on this subject other than Doug Rex. Now, Doug Rex won't need very much introduction to many of you, as he's one of the most famous gastroenterologists in the world. And has taught us a lot on about colonoscopy tips and tricks. He is currently the president-elect of the American Society for Gastrointestinal Endoscopy. So, Doug, we look forward to your talk.
Hi, everyone. This is Doug Rex saying hi from the U.S. I wish we could all be together in Ireland for this meeting. I've not been to Ireland before, and my wife and I were planning a week-long visit last May around the meeting, and I hope we'll still be able to do that and see your beautiful country someday. But for today, I'm glad to be with you virtually and discussing endoscopic resection of large colorectal polyps. So a preliminary comment about conventional EMR, that is inject and snare resect EMR. There's a trend toward limiting snare size to about 15 to 20 millimeters, especially in the proximal colon. It seems to be associated with a lower risk of muscle injury during EMR. Now, if you're doing underwater EMR, one of the advantages of that technique is to get on block resection. You have a greater chance of achieving that for lesions that are sort of in that 20 to 35 millimeter size range. So a bigger snare could be appropriate for underwater EMR, but for conventional, try to limit it to 15 to 20 millimeters. Stiff snares in general are useful for EMR. In terms of cautery settings, the traditional thinking was that it was better to use cutting current because it seemed in uncontrolled studies to be associated with a higher risk of immediate bleeding, but a lower risk of delayed bleeding. And of course, it's delayed bleeding that's the real problem when people have to come back to the hospital. Whereas coagulation current seemed to cause less immediate bleeding, but more delayed bleeding. However, in a randomized controlled trial just published in Gastro from the US Polyp Consortium, there was no difference in delayed bleeding between endocut Q and forced coag current. Now, maybe the lesson from that study is that both of these currents were delivered using microprocessor controlled current, as opposed to the older generators that deliver a fixed output of power. I think the other thing that we've learned is that if you squeeze the tissue really tightly with a snare before you step on the pedal and deliver the diathermy, the snare has very high current density and it tends to come through the tissue very quickly, and you get less burning. And so that's a way to limit thermal injury, which you can judge by just looking at the defect. If it keeps that nice blue color of the contrast, you know you've effectively limited thermal injury. If it looks whiter and more charred, then there's more thermal injury, which may still be associated with an increased risk of delayed complications. But right now, the state of the art is use the current that you want. I would advise in general to squeeze the tissue tightly and still try to transect it quickly, even if you're using a microprocessor controlled coagulation current. For other steps in EMR, for control of bleeding, we want to use soft coagulation current, whether it's with the snare tip or the coag grasper. Soft coag current is low voltage compared to forced coag. You can control bleeding very effectively, but less depth of injury. For hot forceps avulsion, endocut I rather than endocut Q. In our first publication, we used the 313 setting, but since then, I've cut way back, so using almost pure cutting current on the 141 setting. And then for underwater EMR, you can use a variety of currents. This is the current that Ken Binmoller reported in his original publication, but a number of things can be used. APC, almost no role really now in EMR. Of course, we have to assess these lesions very carefully before we remove them. The type 1 lesions, the serrated lesions, a very strong trend toward removing them by cold resection. Some controversy as to whether or not you need to inject, maybe just piecemeal these out with a small snare without injection. I prefer injection because it just gives you such excellent delineation of the margins. For the adenomas, it's not as clear that we can have adequate recurrence rates, adequately low recurrence rates with cold EMR that's under study. And of course, all of these lesions, but especially the adenomas, we need to search the surface for changes in the vessel pattern, disruption of the vessel pattern that indicate deep submucosal invasion. That is more than 1,000 microns of submucosally invasive cancer, because when that's present, when those features are present, it's very specific for deep submucosal invasion. The patient's not really a candidate for either EMR or ESD. For the adenomas, we also want to assess the morphology first as either granular or non-granular, and then the subtypes of granular, the homogeneous, where the bumps are pretty uniform in size. Very low risk of cancer with homogeneous granular LST, about 1 or 2%. The mixed nodular, where there's one or more larger nodules, often sort of firm looking, maybe a little bit of color change in the nodule. That lesion has a 5 to 10% risk of submucosal invasion. In general, the granular lesions with less submucosal fibrosis than the non-granular lesions. Subtypes of non-granular, the flat elevated, still a very low risk of cancer, as opposed to the sessile and pseudo-depressed types, which have a higher risk of invasive cancer. This is the nice 3 pattern. If you look in the edges of this granular adenoma, you can see the vascular pattern is intact. That's the nice type 2 pattern. But down in the base of the lesion, the vascular pattern is disrupted and amorphous. That's nice 3 or Kudo 5, usually seen in association with some change in the morphology, some depression or ulceration. But when that is present, there's deep submucosal invasion, and the patient's really not a candidate for any type of endoscopic resection. Here's an example of getting burned on this. This is a granular lesion in the sigmoid, pretty big, sort of going around a curve. Tried very carefully to inspect the entire surface of the lesion, but it was difficult to see all of it. And here you can see at the very end of the lesion, you can see we've resected quite a bit of this lesion using EMR, but at the very end of it, you see this morphologic change, and you can see even in white light that the vascular pattern here is disrupted. So I subjected this patient to the risks of endoscopic resection for no benefit, because they're still going to require surgical resection. So a reminder to try the best you can to inspect the entire surface of the lesion carefully before proceeding with endoscopic resection. Now, for pedunculated lesions that have overt changes of cancer, this is a pedunculated lesion with ulceration on it, nice 3 features in the ulceration. It's still okay to proceed with endoscopic resection, even though a lot of these lesions are going to have unfavorable histologic criteria. So you wouldn't do this at all with a flat or sessile lesion, but I think it's okay to still do it with a pedunculated lesion. I like to still use low power coagulation current to transect the stalk. We almost never see hemorrhage with this, at least acute hemorrhage. And I prefer to not use the detachable snares really with any big pedunculated polyp. And the detachable loop to prevent bleeding is what I'm referring to. And the reason is that I find that it always kind of moves me up a little closer to the head of the polyp in the resection. And if we have cancer, one of the things we always are going to have to look at the measurement of is the distance between the cancer and the resection margin. So I would rather cut the stalk first and then haul this obviously malignant polyp out if needed, but then close that defect with clips rather than using the detachable snare beforehand, just so we can cut a bit lower on the stalk. Here's a non-granular flat elevated lesion, and some people might say there's a little bit of pseudo-depression here, but I think it's very little. This is a very good candidate, I think, even for traditional EMR, very low risk of cancer. Here, on the other hand, is a non-granular lesion with pseudodepression. This is a better candidate for en-bloc resection. A lot of these are not very big. You may be able to get it out by EMR, but underwater EMR or the use of the full thickness resection device up in the colon can be an alternative to ESD. Here is underwater EMR. Here we don't inject, and it's really injection that tends to make these lesions bigger, more difficult to get on block. So here we rely on the floating process and potentially can get a bigger snare, get larger resections. This one I'm going to do piecemeal, but this is an approach that can increase the chance of an on-block resection with a modest size lesion. For the serrated class lesions in general, cold EMR has now become just extremely attractive. Several studies show recurrence rates varying from 1 to 8%. This is a patient with serrated polyposis syndrome. You can clear large numbers of these lesions from SPS patients with very low risk of complication. I still prefer to inject them. I think for serrated lesions, the contrast does give excellent delineation of the edges. The entire resection is cold, and we rely on resecting a wide margin for completeness of resection. Use a diminutive snare and just kind of patiently move from one side of the lesion to the other. No need to close the site afterwards with clips. Just a fantastic development for serrated lesions. Here is the granular lateral spreading adenoma, and these are the biggest lesions that we see in the colon. One of the problems that we see in the U.S. is very large numbers of patients with benign colon polyps still being sent for surgical resection. And granular lesions, I think, make up a really unfortunate percentage of these, partly just because they get so big. These lesions have a very low risk of cancer, and they just can get enormous before they develop cancer, but they have very little submucosal fibrosis. They're excellent candidates for removal by EMR, and there's really no need for ESD because of the very low risk of cancer. If you go the surgical route, you're looking at an overall in the US 0.7% risk of mortality, much higher than the risk of endoscopic resection. The costs and morbidity are also much higher than endoscopic resection. So pretty straightforward process, just moving from one side to the other. The granular lateral spreading tumors are really an excellent candidate for endoscopic EMR. If there are areas during EMR where you can't get a hold of the lesion with the snare, then avulsion is the way to go. It can be done hot. That's the way I prefer it. The technique is grab the tissue, tent it up, and then tap on the yellow petal, the endocut eye current, and it'll come right off in the same plane that you were snare resecting in. The alternative is to pull it off with cold forceps and then touch up the base there with the snare tip on soft coag. But I just think it's cleaner to do it hot. It's been very safe in our experience. But I think the key concept is those little flat areas should no longer be ablated with APC. If you do that, you're going to have higher recurrence rates. So avulse rather than use APC. Once you've got the entire lesion resected by the snare and using avulsion if you need it, then you're going to burn up the entirely normal edge pretty aggressively using the on soft coag. So the modern EMR defect at the end has this white burn around the edge of it, and in the Australian randomized trial, this reduced the recurrence rate from over 20% to 5%, and at the virtual DDW meeting, a multi-center study from Michael Burke's group showed a recurrence rate of about 1%, which is basically the equivalent of ESD. So recurrence rate now with conventional EMR is no longer an argument for ESD over EMR. It's just a fantastic development in in EMR. Now, there's a lot of interest in whether or not we can extend cold resection comments to large adenomas. And here is a homogeneous granular LST in the proximal behind 3/4 or more of the circumference, extending up on to the ileocecal valve down into the cecum. This lesion is going to be too large to clip close. And so if we take this off using electrocautery, we're going to probably incur a risk of 20% or higher of a delayed hemorrhage. And so the question arises, should we try cold resection techniques? Now, again, if you've got a significant sessile component, then cold techniques are not going to work well, but they do work pretty well for flat Paris 2A techniques. And even if we do end up, when the randomized controlled trials are done, having a higher recurrence rate with cold resection, we're going to be dealing with a recurrence that's probably very small. We've learned good techniques for dealing with recurrence that are on scars at follow-up. So I think this is a pretty attractive way to go from a 20+% risk of delayed hemorrhage with a lesion this big to a risk of delayed hemorrhage that is negligible. And here you can see we're removing the portion on the valve. And here we are later in the process. You can see the fat that's exposed up on the ileocecal valve and this very large defect that we've removed entirely by cold EMR techniques. So I think we need our randomized controlled trials to understand recurrence rates, but this can be pretty attractive even outside of a trial in current practice. So here again is the granular LST, the excellent candidate for EMR. On the right, however, is a rectal lesion that has a big nodule in it, the granular mixed LST. And in the recent Italian multi-center trial, the granular mixed LST in the rectum had a 20+% risk of cancer. We don't know how often it was just superficial cancer, but I do think that this lesion, when it's in the rectum, is currently the single best candidate for ESD. There isn't an endoscopic alternative for ESD, and certainly the morbidity of rectal operations are much higher than that of colonic operations. So I think that this is becoming our clearest indication to take the extra time, risk, etc., to perform ESD. In terms of EMR technique, a couple things to emphasize are dynamic injection. This is just the process of, as you get the needle in the submucosal space, lifting the needle toward the lumen as the injection occurs, shooting that fluid into the upper portions of the submucosa, keeping a lot of distance between the cushion and the muscularis propria. That's dynamic injection, very helpful during. And then, the basic process for these very large lesions, this is obviously a rectal lesion, pretty much homogeneous, got some sort of nodular areas, but not the kind of nodules that I think are really concerning for cancer. And so the basic process is we start at one end and just inject and resect and just repeat the process over and over again, injecting and resecting, but a very efficient way to remove lesions that endoscopically appear to have a low risk of cancer. Here's a bit of bleeding as we go. We can control that with the snare tip on soft coag. And then the final step is electrocautery with the snare tip on soft coag of the entire margin. So those are the basics of the. It is important that we be able to identify muscle injury that occurs during EMR. The contrast, as I mentioned, has a couple of roles. In serrated lesions, I think it's very helpful for delineating the margin. Not so important for the adenoma. But you'll see as this EMR progresses here that we're going to get a muscle injury. In the recent Australian report, this occurred in about 3% of EMRs. I get it in a lower rate than that. But perhaps here I was a bit aggressive. Maybe this is too large a piece of tissue, but when you see these thick white bands in the base of the defect, that's cut muscle, and you've got, you can still finish the EMR, try to not overinflate the colon with your carbon dioxide, but you need to close that, or there's a very high risk of a delayed perforation, and usually closing it with hemostatic clips is adequate. Here is the specimen in the colon, and here it is after we've pulled it out, set it on the table. That's cut muscle, the target sign on the base of the lesion. Here is the progression of type 3 muscle injury. You can see the cut muscle right here. This is in the transverse colon. Really, the two most dangerous parts of the colon are the cecum and the transverse in terms of perforation. If you do get this type of muscle injury and or perforation, the holes are usually pretty small like this, and often they can be closed with hemostatic clips. I think in general that's easier than taking the scope out, loading an over the scope clip, etc., coming back in. In our experience, you can close these very effectively and safely with hemostatic clips. We usually place them quite tightly together. Of course, in this case, we're going to admit and observe, give the patient probably antibiotics, but expect them to be able to be managed without surgery. We have to have methods for control of bleeding during EMR, and more than 90% of the bleeding can be controlled using the snare tip. And again, when we're using the snare tip, we want to be using it on the soft coagulation setting rather than the forced coagulation setting to limit the amount of thermal injury that occurs. For more aggressive bleeding, we want to have a grasping tool available. The coag graspers are nice in this regard, and I think the advantage of this tool is the flat surfaces as opposed to the hot forceps, which have teeth on them, so a little bit less chance of tearing the tissue. But if you use the hot forceps cautiously, they also can be used. But again, using the soft coag current. In general, the technique is to grab and then lift a little bit and then apply the current. We're pretty aggressive here because this was very, very aggressive bleeding, but a good tool to have around for EMR. In terms of prophylactic closure, the current science is that for lesions proximal to the splenic flexure, 20 millimeters or larger, removed by electrocautery, we should consider closure using a zipper technique. We often can close quite large defects, but certainly not all of them. Not some of the giant defects are just too large to close. So in conclusion, we've talked about conventional EMR, the paradigm of snaring followed by avulsion if needed, and then finally snare tip soft coag to the normal edge. That's the current state of the art for conventional EMR. Cold EMR, now pretty well established for serrated lesions, and a lot of interest in whether or not we can extend it to the Paris 2A adenomas, and the great advantage of it, the low risk of complications. En-bloc resections up in the colon, increased use, I think, of underwater and in some cases the full thickness resection device can help us extend to intermediate sized lesions, the en-bloc concept. In the rectum, lesions that are, it just says 20 millimeters, but I think really the best established is 40 millimeters in size or larger in the rectum, consider ESD. And then for lesions that are 20 millimeters or larger, proximal to the splenic flexure and removed by electrocautery, not cold techniques, we should consider clip closure in that setting. So those are my comments. I hope they'll stimulate some comments and questions from you. And thanks again for the opportunity to join you in this great meeting.
Hi, Doug. Thank you so much. Thank you so much for a masterful talk. and for joining us at the ISG, albeit virtually. We will definitely have to get you to Ireland to fulfill your dream of
Thank
traveling
you. Thank you
this
so much.
country. So
Yeah.
I'm Tony, and this is John Burke, my surgical colleague.
Hey, Tony.
So, John, are there questions from the audience?
So there absolutely are. Yeah, I'd like to echo Tony's comments. That was a wonderful talk. I really enjoyed it.
Thank you.
So the first question is, do you have any thoughts on how to quality assure EMR in routine clinical practice?
Gosh, you know, obviously one way is with complication rates, but in routine clinical practice, I guess the issue is whether or not there's going to be enough of it. And then the second one is recurrence rates. And a third is the percentage of lesions that are, you know, particular sizes that are being sent to surgery. That's probably the most important thing to do. So I would probably focus on those three endpoints, and depending on how things are set up, whether the EMR is being focused within one individual or whether a number of people are participating in it, either, you know, for the group. Obviously for quality, it's best to get some individual feedback, but I probably would focus on those three things: complications, especially perforation, and recurrence rates, I think, and then avoiding the use of surgery for obviously benign lesions.
Great. Joe Garvin asks, do you have any strong feelings in relation to piecemeal versus en-bloc resection of large sessile polyps?
You know, I think it all depends on the assessment of the lesions. So for the homogeneous granular lesions, which actually are the majority of lateral spreading lesions, the risk of cancer is really very low. And I don't think that we have to push it with regard to trying to get en bloc resections, especially if it's going to compromise safety. So as I suggested, when you're doing traditional EMR, inject and snare resect EMR, trying to limit snare size to around 15 to 20 millimeters, I think helps to reduce the risk of muscle injury. And I would encourage most people in practice to try to stay on the side of safety with lesions that have a very low risk of cancer. Obviously, when there's a greater risk of cancer, non-granular lesions that have 1S shape or pseudo depression, then en bloc resection has potentially a greater value, primarily for avoiding surgery if cancer is present.
Right. Do we have time for one or
Yeah.
two more? So we have two questions here on antithrombotics and NOACs. What's your feeling on restarting anticoagulant medication after EMR?
Yeah, sure. Yeah, it's really important issue. You know, we always want to take the side of erring on the risk of bleeding. We'd rather see bleeding than a risk of thromboembolism. On the other hand, I think getting the involvement of the cardiologist or whoever has been prescribing the anticoagulant or the antiplatelet agent is important, because they're going to be able to give you a better sense of the real risk of thromboembolism and how soon you need to start. If I get the signal from talking to that person that the risk is actually fairly low, then I usually will try to strike a deal with them to delay things a bit, whether it could be several days or, you know, whatever sort of permission they give. On the other hand, when they say the risk is really high, then you know, we're going to go ahead and restart the drug the same night or the next day, whatever they say, and accept the risk. I think that with cold techniques, the risk is still quite low. The main agent that I've seen bleeding with, even with cold resection, has been heparin. So if you have to start sub-Q heparin, you know, in the short run, which that the need for that has really been challenged in the last few years, that we would need to bridge people, then I occasionally will even close lesions that I've removed cold if I think under that circumstance. But otherwise, we've not seen much bleeding with the DOACs or with warfarin.
Great, great.
And cold techniques, I should say.
Okay.
So thank you very much, Doug. I think if there are any more questions, if you don't mind answering them online, and then it will pop up for everybody to see. But appreciate your time and your expertise in speaking to us. And
thanks for having me. I hope you guys have a great meeting, and I really am hoping to be able to visit Ireland one of these times. So
definitely,
good luck, and hope to see you.
Definitely, thank you. So I'm going to hand over to John now.